So I'm going to talk about cervical and lumbar arthroplasty, and what that is joint replacement for the spine. And this is a relatively new technology. So spinal arthroplasty, aka artificial disc or total disc replacement. First FDA-approved device was in 2004 for the lumbar spine, 2007 for the cervical spine. So the lumbar arthroplasty goes back to the 50s. The first reports were made, and JFK supposedly had the Fernstrom ball, which is shown here, and that's a little stainless steel ball bearing that they put into the disc base. That was the arthroplasty back then. And the first case series was in the 1960s. So that was an interesting idea. So why arthroplasty? It's a motion-preserving alternative to spinal fusion. And you know, people think of spinal fusion, they think, oh, I can't move, I'm going to be stiff. And so this is supposed to be a solution to that problem. There's a theory that there is adjacent segment degeneration which occurs after spinal fusion. So if you fuse one level, the level above or below may see more stress and degenerate, and people may need further surgery. We see it happen, but it's really a theory. We don't know that it is definitely a result of fusion as opposed to just getting older and wearing down. But a spinal fusion involves putting screws and rods into the spine with bone graft and locking the bones together so that two bones or more will heal together into one bone. The fusion is actually bones growing together. So just a little lumbar anatomy. So the spine's made of bones which are, was that upside down? Oh, so anyway, the spine's made of bones that stack up on top of each other with the lumbar discs, which are the cartilage joints between, and for every disc there's two joints in the back of the spine for each two bones that they work together, and the space inside the spine transmits the nerves from the brain that go down to your legs. So this is just to demonstrate basically that there's some range of motion in the lumbar spine, rotational force, bending, and then also there's compression, which the discs bear. And then this is just showing you lateral bending, forward bending and extension. So these are some problems that we treat with fusion. Spondylolysis is a condition where you have a fracture in the bone in the spine. Typically occurs at a younger age, and over time you develop instability and disc degeneration, malalignment, and nerve compression. And that's treated with a fusion. So, you know, can you treat this with an arthroplasty? The answer is no, because this is an instability problem and a structural problem. Spondylolisthesis and stenosis occurs predominantly in older people, and again you have malalignment. This is due to a degenerative instability that happens over time. You get arthritis associated with that and nerve compression, and that's treated with fusion. So can this be treated with an arthroplasty? The answer is no. So what did I do? So trauma. This is a lumbar fracture. Can you treat it with a arthroplasty? Absolutely not. This is a problem that requires reconstruction and fusion. So those are common things that we treat with a fusion. Degenerative disc disease, or arthritis, is a condition where a disc wears down, the cartilage collapses, dries out, you see changes in the bone above and below, and that can cause back pain in some people. And this is sometimes treated with fusion as well. So, you know, fusion is the standard treatment. Can you treat this with a fusion, with an arthroplasty? Yes, you can. So, but fusion is standard for this. So getting on to the devices, the Charité was the first device, was approved in 2004, and for single level arthroplasty from L4 to S1, so that's the two lowest discs. It was touted as likely to make fusions obsolete. There was a big hubbub about it, and it's off the market in the United States for now. The ProDisc is the other FDA-approved lumbar disc, and it's a similar design. These both have two metal end plates with a plastic insert in between, and they're sort of a ball and socket design, so they articulate and allow motion. So the pros of lumbar arthroplasty, mainly preservation of motion, but you know, if you do a fusion on someone for low back pain, a single level, they don't complain of loss of range of motion. I mean, it's just, you don't see it. If they do well, they do not complain. Reduced risk of adjacent segment degeneration is really unclear. The whole theory of adjacent segment degeneration is just a theory. There are guys that argue it doesn't exist. We see plenty of people that over time develop numerous problems that stack up in the spine without surgery. And people have also seen adjacent segment degeneration after arthroplasty as well. It's argued there's a quicker recovery. I think that's questionable. Cost reduction, probably the most true thing, but also probably questionable. And improved pain relief is definitely not clear. Each device has a FDA IDE study that shows a great outcome for the device, but I think there's a lot of reasons why you got to take those results with a grain of salt. There's a lot of biases in there, and a lot of people don't really believe it. So the cons, if you have a device failure, it's a big deal. If you got to go back in and take it out and revise it, it's dangerous, it's high risk, there's vascular injuries, ureteral injuries, and experts at meetings have gotten up and said, if you have this problem, you got to take it to a tertiary care hospital where someone does 100 of these a year to take it out because it's really high risk. So that's, if I can't fix it, I don't want to do it. Death is a result of this when these things fail in some cases. Maybe not a lot, but it's been reported, and a lot more frequently than you would think compared to a fusion. Chronic pain's been reported. Heterotopic ossification, meaning that the disc actually fuses despite the fact that you're trying not to fuse it. There may be wear debris that causes inflammatory problems in some cases, and you just don't know in the long term how it's going to turn out. With a fusion, once it fuses, you're done there. You may have other problems in your spine, but the fusion is fused, and it's going to stay that way. If you have an artificial joint in your back, we don't know what's going to happen over 50 years until 50 years go by. So that's uncertainty. And then if you have an MRI after arthroplasty, you can't see anything around it because of the artifact, which is a diagnostic problem. And this is just telling you why it's dangerous. So in these devices go in through your abdomen through an anterior approach. And the spine is behind the big red and blue things, which are the blood vessels that go to and from your heart. And you got to move those to some degree to do the surgery. If it falls out, it falls into those blood vessels, and there's a lot of scarring involved. And if you go in to revise that, it's very dangerous because of that. The ureter also goes from the kidney down to your bladder, and that's frequently involved when you go back in. So there's a lot of potential for complications, and that's the main drawback as far as I see it. Here we see a ProDisc that's failed and a Charité that's failed. You can see the cord came out, the little wire line on it. And you got to take that out and fuse it if it fails, and taking it out is the problem. So in summary, I don't think it's applicable to it's definitely not applicable to the majority of fusion candidates, and the benefits are questionable. The real world complications are potentially much worse than having a fusion, and a lot of insurers won't cover it and consider it experimental. The Hippocratic Oath says first do no harm, and I think the best way to avoid harm in this case is to stick with a fusion. So that's my opinion on that. Going to the cervical spine, the anatomy is very similar. Bones stacked up on top of each other with the discs in between, and two facet joints in the back of the spine for each disc. And then the spinal cord is transmitted from the brain through the tube in the center of the spine. So the first FDA-approved disc was Prestige in 2007, and these are approved for a single level from C3 to C7. This is a stainless steel two-piece ball and socket design that screws into the bone, so it's pretty simple. The ProDisc is the same as the lumbar spine, a three-piece design with a ball made of plastic and a core and end plates made of metal. The Bryan disc was approved in 2009. This is a really different design, sort of an interesting design. This just shows it exploded, and basically it has a little bearing surface in the middle wrapped around a sheath and then end plates. So I think that's sort of cool. And then the Secure C was just approved, and this is another three-piece design with a plastic insert between two metal end plates. So those are the four that are FDA approved in this country. So if you have a cervical disc herniation, typical problem, someone has horrible arm pain and neck pain, and they have a cartilage disc that's ruptured and a piece of it's pushing on a nerve. And this is a cross-sectional view, and on the left side of your screen is disc pushing on the nerve, and that's pretty bad. And so you fail conservative therapy, and you can't take the pain, you decide to have surgery. And so can you do an arthroplasty for this? The answer is yes. So if you do a standard anterior-cervical discectomy, you make an incision in the front of the neck, and to get from there down to your spine, it's about 3 minutes of dissection. It's very simple. It's a clear corridor, and it's very easy to do. Then you take out the disc, you take out the entire disc, and you take the pressure off the nerve, so the nerves are free, but now there's no disc there. So at this point, you have the option, the standard treatment, which is very well proven and has many years of follow-up, is a fusion. And a fusion involves basically putting in either a cage made of plastic or bone graft and a plate and screws and allowing those bones to grow together. That works extremely well. The alternative will be an arthroplasty, where you put in an artificial disc instead, and that preserves your motion. You see flexion and extension there, and that's moving well. So that's where it goes. Another application I think is interesting is if you have, why are these upside down? These weren't upside down when I made the talk. I'm blaming someone else. So if you have a fusion, this lady had a 2-level cervical fusion, and she has a plate and screws. She had a disc herniation above, which is pretty bad. She felt conservative treatment. The disc above that one was actually bad too. You can't really see it here, but so that was pretty degenerative but not symptomatic. She felt really stiff after the fusion, and she didn't want a fusion, and so she wanted an arthroplasty. And so, you know, we went in and we took out the plate and we put in an artificial disc after taking the disc out. And you know, we don't know how this is going to fare over many years, but it's a safe way to treat things if people want it. So the pros for the arthroplasty and cervical spine are motion preservation, questionable reduced risk of adjacent segment degeneration. The big difference, the major difference, is that if you got to revise these, it's safe and it's easy. It's very easy to go back in and take it out and do a fusion if you have to. That's a major difference between the lumbar spine. I like the Prestige because it has a robust design. It's just 2 pieces with a metal ball and socket, and the screws hold into the bone. I can't really envision a way that this could really fail in a catastrophic way. And you know, that's important. You got to consider the worst case scenario. Whether it's going to be good in the long term, we don't know. The cons, long term unknown. Chronic pain, wear debris, heterotopic ossification, insurance issues. This shows you an MRI that shows you how bad the MRI is around an arthroplasty. You can't see anything for a few levels around it, so that's actually a significant issue. So in the future, you know, they're working on lateral discs that go in the lumbar spine through a lateral approach, and that's supposed to obviate the problems from it slipping out because it doesn't fall into the blood vessels. That's experimental at this point. Posterior joint replacements, and then circumferential joint replacements with artificial disc, as well as posterior joint replacements. And you know, these are things that are experimental in various degrees of development. Don't know where they're going to go. And this just says, every time I try to entertain my friends, my back kills me. That might be an arthroplastic candidate. So that's all I got.